Good morning, everyone. Bonjour tout le monde. Justement pour dire, notre discussion d'aujourd'hui sera bilingue. Ça veut dire que vous pouvez poser les questions ou soumettre les commentaires en français ou également en anglais. Donc, si vous avez besoin d'une traduction, voilà, nous avons les... pour la santé mentale de nos traducteurs, je vais continuer de parler en anglais. So just a note, our panel today will be bilingual. There's translation available both online and here in the room. We'll have a panelist speaking in French today, so if you need translation support, please get that ready now. And for the sanity of our translators, I'll be speaking in English from here on out. So just to start, I'd like to begin by acknowledging that we're meeting today, this second panel of the conference on the traditional and unceded territory of the Algonquin Anishinaabe Nation. And when I reflect on the theme of this year's Canadian Conference on Global Health, Rethinking Partnerships, Paradigms for Global Health, I wonder to what extent we've actually considered models or philosophies for partnerships that are here closer to home from Turtle Island or what is also called North America. In particular, the Haudenosaunee have a concept called polishing the silver covenant chain, which I learned about from Nathan Wright, who's an elected counselor at Six Nations. Really grateful for the time that he spent teaching me that. The covenant chain is an English translation of root words in the Haudenosaunee language, meaning arms linked together, which is similar to the Western concept of an interdependent world. The idea is there's two vessels traveling down a waterway linked together equally by a chain. What happens to one has a direct impact on another. Of course, the European concept of a chain is not only about interdependence, there's also a firm hierarchy imposed as well. How many times have we heard the term, you're only as strong as your weakest link, as an example. However, what's different about this concept of a silver covenant chain in Haudenosaunee philosophy is the contrasting focus on balance, on friendship, on renewal, because like anything made of silver, the chain needs frequent polishing so as not to tarnish, to stay strong and to stay healthy. If we think of relationships and power structures in the global health world, especially on the issues that will touch upon the health of our planet, how are we polishing those partnerships that we've heard have become too siloed, too vertical, too based on extraction, on domination, on colonization? I think that's a really nice tie-in to our panel this morning. We'll be talking about water, worms, and women's health, intersecting partnerships in planetary health. Partnerships. This is the term that we're hearing a lot over this conference. And in Canada, clearly a debate has emerged on this topic of the global health partnership, especially over the last couple of years, especially in light of the feminist international assistance policy. And I think the question that many of us are asking is how do we shift towards an equity-informed partnership model? And some of you actually, attendees of the conference have put out papers on this exact topic this year. The goal of today's panel conversation will be to use zoonotic diseases, especially neglected tropical diseases or NTDs like schistosomiasis, but not only, to explore the importance of multi-sectoral partnerships and country ownership of disease elimination and control. We want to understand how well do the multi-sectoral partnerships established in this health area work? And for whom do they work? Can we improve the understanding of this notion of partnership, especially for planetary health and especially in the realm of zoonotic diseases and NTDs? To accomplish our goal, we'll hear from three fantastic panelists, Dr. Pamela Sabina Mbabazi from the World Health Organization, Professor Margaret Gyapong from the University of Health and Allied Sciences, and of course, Dr. Hélène Carabin from the Université de Montréal. We will also seek to embrace a little touch of chaos this morning in our panel. And so I invite people both in the room and online to submit questions and comments on an ongoing basis throughout the panel. If there's something that you think is important and should be added to the conversation, we welcome you to share it. One note, I will retain the right as moderator to gently cut you off, gently reframe you, or perhaps gently steer the question in a direction that serves the objectives of our panel. So with that, I'd like to turn it over to our panelists to introduce themselves and maybe also share what's an idea that you would like to advance over the course of this panel. And why don't we start with Pamela and the video that she submitted for us.
Good morning, good afternoon. My name is Pamela Sabina. I am a medical immunologist working with the Department of Control of Neglected Tropical Diseases at the World Health Organization in Geneva, Switzerland. I am grateful for the opportunity to be part of this panel during this year's conference theme that is focusing on rethinking partnership paradigms in global health. Indeed, for neglected tropical diseases, it is impossible to attain any public health gains without considering their social determinants, including the impact of connections between people, animals, and ecosystems. All of these human diseases have an element in their transmission that is facilitated by dominant animal and environmental factors. Neglected tropical diseases, or NTDs in short, are ancient diseases of poverty that impose a devastating human, social, and economic burden on more than 1 billion people worldwide, predominantly in tropical and subtropical areas among the most vulnerable marginalized populations. The NTDs prioritized by the World Health Organization are a medically diverse set of 20 diseases and disease groups with a singular commonality: their devastating impact on impoverished communities. The past decade saw significant progress in the battle against neglected tropical diseases, including new preventive measures and interventions, expanded donor support, new strategies and guidelines, and strengthening of related structures, collaboration and country commitment. The establishment of public-private partnerships has vastly facilitated progress towards the elimination and control of NTDs. Pharmaceutical companies have donated nearly 3 billion tablets of safe, quality-assured medicines annually to support the control and elimination of neglected diseases in countries where they are endemic. For 5 consecutive years between 2015 and 2019, more than 1 billion individuals received treatment for at least one NTD each year. The NTD community presently holds a Guinness World Book of Records for the highest number of medicines, that is more than 200 million doses, donated and distributed to sites in a 24-hour period. These drugs represented and continue to represent hopes of millions in ending suffering for the affected individuals. None of what has been achieved would be possible without the generous support of some of the world's leading pharmaceutical companies, such as Bayer, ASI, Gilead, GSK, Johnson & Johnson, MSD, Merck, Novartis, Pfizer, Sanofi, to mention but a few. The complexity of the Sustainable Development Goals and the current state of the planet requires a paradigm shift in the way we work together. The new NTD Roadmap, titled Ending the Neglect to Attain the Sustainable Development Goals, a roadmap for neglected tropical diseases 2021 to 2030, has been prepared through an extensive global consultation and was launched in January this year. The roadmap presents 3 essential paradigm shifts focusing on 3 foundational pillars, namely accelerating programmatic action for impact, that's pillar 1, moving from vertical programming to holistic cross-cutting approaches, that's the second pillar, and changing operating models and culture to facilitate country ownership, that's the third pillar. These 3 foundational pillars for NTD programs are in alignment with the conference theme for this year. We look forward to sharing, learning, and further growing of partnerships that will support the implementation of this NTD roadmap to 2030 in light of the values of compassion, equity, inclusion, and respect for human rights. I thank you.
Pour permettre aux francophones de pouvoir entendre quelqu'un parler dans la langue de Molière.
Merci.
Donc, pour ce qui est des maladies tropicales négligées, ce qu'il faut réaliser, c'est que la majorité sont zoonotiques. Autrement dit, l'éradication de ces agents infectieux-là est à peu près impossible parce qu'il y aura toujours un réservoir animal non humain. Les humains étant des animaux aussi, mais il y a plein d'autres espèces animales dans le monde. On est juste une mini espèce dans un ensemble énorme. Et les agents infectieux, ben, eux, ils vont s'adapter pour pouvoir se transmettre, quelle que soit l'espèce animale. Donc, quand on pense au contrôle et à l'élimination des maladies tropicales négligées, on ne peut pas penser strictement à une mini-espèce animale qui est l'humain, parce qu'on n'y arrivera pas. Puis pour être en mesure de faire ça, il faut commencer. Et puis, je pense que le monde, dont l'OMS, la FAO, l'OIE commencent à collaborer pour penser plus multisystémique. Au fait que la majorité des maladies que l'on connaît dans toutes les espèces animales sont le résultat de l'interface entre les animaux, les humains et leur environnement, mais l'environnement non seulement physique, mais l'environnement socio-culturel. Parce que les animaux aussi vivent en communauté. Les animaux domestiques, les chats, les chiens vivent en communauté dans les communautés humaines, mais les animaux sauvages ont leur propre communauté, leur propre échange. Et l'animal humain impacte ces mondes-là, ces communautés-là, en ayant une population de plus en plus grande qui s'étend vers les campagnes, qui s'étend vers les milieux ruraux, puis qui va donc pousser ces espèces animales-là ils vont complètement changer leur communauté, leurs échanges les uns les autres, puis ils vont encourager une densité animale plus grande, puis forcer des contacts entre animaux et leur environnement non traditionnel qui peut pousser justement à plus de transmission d'agents infectieux. Bon, ça c'est... Puis ça peut être pas seulement les maladies en émergence, on parle beaucoup de maladies en émergence avec la COVID, mais les maladies tropicales négligées aussi. Pensons à la rage, par exemple. Même au Canada, les changements climatiques font en sorte que les renards arctiques viennent en contact avec les renards roux. Et il y a la transmission de la rage qui traditionnellement ne survenait pas à cause des changements climatiques. Puis par la suite, la rage pourra se faire transmettre à des chiens domestiques dans les communautés inoues, qui par la suite devient un facteur de risque pour les humains. Ça, c'est une maladie tropicale négligée. Puis souvent, ce n'est pas toujours les zoonoses, ce n'est pas toujours les animaux qui infectent les humains. Parfois, c'est vraiment dans les deux sens. Si on prend l'exemple de la cysticercose, Téniasolium, qui est aussi une maladie tropicale négligée, c'est l'humain, l'hôte définitif. C'est l'humain qui a le ver adulte, c'est l'humain qui contamine l'environnement et qui infecte le porc. Puis après, le porc, lui, infecté, se fait manger par l'humain. Alors, l'humain est le centre du problème ici. Ce n'est pas le porc. Donc, il faut commencer à penser comme ça, quel impact est-ce que l'humain a sur toutes ces interconnexions-là. Puis c'est seulement en travaillant sur ces interconnexions-là, sur ces systèmes-là, tous ensemble, sans seulement penser aux bénéfices strictement pour l'être humain, sans étant complètement anthropocentriste, que l'on va pouvoir régler certains de ces problèmes-là, et en particulier les maladies tropicales négligées, parce que dans ces cas-là, il y a un rôle très important, tant de l'environnement que l'animal humain, que beaucoup d'autres animaux. Donc, ce sur quoi je veux insister, c'est une seule santé. Si vous n'avez pas encore compris, le One Health va pouvoir contribuer largement à la carte de route, justement, de l'OMS. Et d'ailleurs, c'est ce que l'OMS tente de faire, c'est d'incorporer l'approche une seule santé dans la carte de route pour le contrôle et l'élimination de plusieurs maladies tropicales négligées.
Merci. Margaret?
Thank you very much. I couldn't help but smile when I heard Hélène say the humans are at fault. You know, it's the first time I've heard. My name is Margaret Gyapong, and I work with the University of Health and Allied Sciences. Before then, I worked in the Ministry of Health. So I'm interested in health systems and ensuring that our research actually informs program implementation and policy. So although I've worked in neglected tropical diseases for several years, and I've done a review on gender and tropical diseases, including schistosomiasis, in 2015, I was confronted with FGS, which is a consequence of schisto, and I had never encountered it before. But I got very interested because women and girls performing their normal roles, washing, bathing their children, go into the sources of water that they have, the only source that they have. Oblivious to anything, they get infected by these diseases. Now, it affects their entire genital system. So when they have pain, etc., they would visit a health facility and they are sent to a gynecologist who looks at them based on their training and decides what is wrong with them. Either you have an STI, or if you complain about infertility, they start taking you through all the rigorous processes of ensuring that you can have children. So the gynecologist will not think NTD and will not ask a simple question, where do you live, or have you been swimming in any water sources? The NTD program manager is interested in mass drug administration. So community drug distributors are trained to distribute tablets. School teachers are trained to give praziquantel to children. That's it. So they don't think gynecological problems of women, and the gynecologist does not think NTDs. So our women fall between the cracks of the health system all the time. So traditionally, we've been dealing with diseases in a fragmented way. The gynecologist is trained to deal with a particular issue and not cross carpet. The NTD person deals with his condition and doesn't cross carpet. Same with everything. Now, let me read to you two quotes from a young girl and another from a midwife to put some of these things in context. The first one: when I reported to the clinic with bloody urine, vaginal itch, discharge, and a lower abdominal pain, they referred me to the family planning clinic, where the nurse asked me the last time I had sex and the number of men I slept with, and told me the symptoms were STI. She gave me some medicine and told me to abstain from sex. But I've never had sex in my life. I'm only 14 years. The medicine she gave me did not work, and I finally went to the drugstore where they treated me and said it was schisto. This is a 14-year-old girl in an in-depth interview we had with her. The second one: I have worked here for 12 years and have never seen a girl report with bloody urine. It is always the boys. I don't think girls get the disease from the lake like the boys. So here is a healthcare provider who should know and guide the young girl with the condition she has brought. She has no clue about it. And this is the girl who has gone to the health facility just to present her case, and she's told she's a bad girl, she's sleeping around. A follow-up with this girl showed that she's not going to go to the health facility anymore. And they are also concerned that the workers in the health facility are talking to their parents and disclosing the private issues they've brought to them. So we're actually talking about a condition that is misunderstood and misdiagnosed and probably not taught in our training institutions. And we have a big challenge when we come to that. If you look at FGS, the person who has it has an increased risk of HIV because of all the challenges in the cervix and stuff like that. There's a risk of infertility because of the stigma. They have mental health issues. Our health workers don't know about it. Praziquantel, if it is not through the mass drug administration program, is not free and is not cheap. So there are different partners that need to come together to be able to deal with this problem and look at the girl in a more holistic way rather than in a very fragmented way. But I'm just excited being in this conference and remembering a couple of years ago when we presented the idea of FGS to Grand Challenges Canada as an NTD that severely affects women and children. And they saw the need to support this within the remit of their maternal and child health program. They could have dismissed it as an NTD and said, we don't deal with NTDs, but they looked at it differently and agreed to support it. And today a lot of traction has been made about it. So I think the issue of looking at people in a more holistic way is important, and the partnerships, the disciplines, and the sectors that need to come together are critical to make this successful. Thank you.
Thank you so much. I'm super excited because there's a through line amongst the introductions here on this idea of a more holistic approach, whether it's holistically looking at the interactions between humans, animals, and the environment, looking at the holistic interactions of the health sector, or looking maybe at the institutional level and how actors are working together. So I think we're going to have an excellent conversation today. And let's take it down first to talking about partnerships, which is why we're here. And each of you has touched on this already a little bit. But maybe Pamela, I'll turn this one to you to start. In the context of your work, thinking from the World Health Organization perspective, what do you consider to be an effective multi-sectoral partnership? What does that look like? And do you have an example that perhaps you could share with us?
Thank you very much, Max, and thank you also to my fellow panelists. I'm also learning and hearing a lot about how we could do these things better. From the perspective of, first and foremost, WHO has several partnerships, and we have a lot of experience of working through partnerships to deliver several programs. There's a lot of progress that's been achieved. If we look at some better known partnerships, like through the TB partnership, the malaria partnership, to advance the global agenda. For purposes of neglected tropical diseases, the partnerships that I shared examples about in my opening remarks have two things. One, they demonstrate there is an element of donation. People come to the table with something to offer at a risk to themselves, because typically these would be like endeavors for which they would undertake for profit. But as an organization, we are not a for-profit agency. So some of the partnerships we engage with, people need to understand that there is no profit for them. And so there is a risk to them. And as WHO, we take on the responsibility to say that with those risks that they are undertaking, we commit to supporting them, use the resources they are bringing to the table or to the work we are doing in a manner that is transparent and we have accountability for. These accountability frameworks are what we put together in consultation with all stakeholders, our main stakeholders being countries. So WHO sits in the middle of the middle spot where we have a partner who's coming to support a global agenda at a risk to themselves or something they could potentially lose, but also in response to an expressed need for a country. We respond to what countries have expressed to us. And so this is what really a successful partnership has been for us. Resources are brought that we can use in response to what country need. We account for these resources transparently through a common framework. And this is what we've seen repeatedly work for those partnerships that have been successful and enabled us to deliver some of the results I shared in my opening remarks. Thank you. Answer. Audio.
She had, okay, we'll continue. You can hear us now, Pamela? Awesome.
Yes.
I think this idea of expressed need being an impetus for partnerships is also kind of interesting because I think maybe FGS is a good example of a type of disease where there isn't necessarily always that expressed need at the community level, or maybe it's because of neglect. Margaret, what does that look like when you're building partnerships around something like FGS that maybe you don't have that level of recognition? How do you build that? How does that feature in the partnerships that you're building from a multi-sectoral perspective?
Thank you very much for that. And you did mention where it's not known, and FGS, as we all know, is not known. But in putting together the first package, let me read our hypothesis, what we said. we said that addressing FGS in a holistic manner will be more acceptable to practitioners, policymakers, patients, and community members, resulting in diagnosis, awareness about FGS, compliance with preventive chemotherapy, and national support for FGS-related policy and training. This is new, and you need to really put in a lot of effort to ensure that people understand where you are coming from and what you are talking about. I talked about my 2015 experience where I was asked to make a presentation on how to put FGS on the maternal health agenda. I didn't know what it was. I didn't know what to say. So I just used my experience from lymphatic filariasis when we started working on it in Ghana for the first time. And the Ministry of Health said, but you are wasting our time. This doesn't kill. Why should we put in a lot of effort to this? But then we had to do a lot of advocacy and bring in non-conventional partners, people in communication, people in health education, people in other fields, to be able to bring attention to lymphatic filariasis. And that is what we are trying to do with FGS. Bring in a lot of the social science skills, because you engage with people, you tell the stories. And in lymphatic filariasis, we got people to take pictures of their condition, explaining how they feel when they have the condition. So that's what we are getting at with this, trying to say we need to bring different partners together. We are bringing family health on board. We are bringing the HIV program on board. We are bringing school health on board and trying to say, yes, we are talking about this as an NTD, but it affects other aspects of this young girl and this woman. And so we all need to come together to work.
Interesting. Thank you, Margaret. Hélène, we had a question come in online for you, actually, and I think it would be interesting for you to address it in light of this question of what do partnerships look like in One Health? And the question is, I think, really asking, what is the benefit of a One Health approach for zoonotic? What is it? How does it work? Why are we talking about it? And what do partnerships in One Health look like?
Oui, ben c'est une excellente question, et d'ailleurs, ça suit très bien les commentaires de Pamela et Margaret, que ce que les systèmes, ce que les gens recherchent à plus haut niveau en général, ce sont justement des profits. Ce sont d'avoir un bénéfice de tout effort investi. Or, avec l'approche Une seule santé, c'est toujours la question qui demeure, quelle est la plus-value de Une seule santé? Parce que, bon, chez l'humain, par exemple, il y a plusieurs échelles qui ont été développées, par exemple, les DALYs, les QALYs, le nombre de cas humains prévenus, le nombre de mortalités prévenues. Mais quand on parle de zoonose, par exemple, comment on fait pour combiner l'impact d'un agent infectieux chez l'humain avec celui d'une vache, avec celui d'un porc, avec celui d'un poulet? On ne peut pas balancer une mort humaine avec une mort de poulet, c'est quand même pas pareil. Alors, comment on fait pour être en mesure de dire qu'il y a quand même un avantage? Bien, si on veut vraiment mettre un chiffre dessus, le seul dénominateur commun, c'est les bénéfices monétaires. Donc, par exemple, si on prend la cysticercose dont j'ai parlé tout à l'heure, ce que ça crée chez l'humain, c'est une infection neurologique avec de l'épilepsie, des maux de tête très sévères. Il peut même y avoir des accidents cérébrovasculaires, dépendamment où se retrouve le kyste dans la tête. Mais les éleveurs de porcs, qui sont d'ailleurs majoritairement des femmes, ont des pertes économiques aussi parce que quand le porc est infecté, il peut être condamné à l'abattoir, s'il va à l'abattoir, ce qui n'arrive pas souvent, ou encore l'acheteur de porc va les payer moins. Ils vont regarder en dessous de la langue, il y a un kyste en dessous de la langue du porc, ils vont les payer moins cher. Puis donc, les femmes subissent les conséquences de la maladie chez le porc parce qu'il y a moins de profits qui peuvent ensuite être utilisés pour envoyer les enfants à l'école, les habiller, les nourrir, tout simplement. Donc, Et ça, c'est seulement le bénéfice monétaire. Il y a aussi plein de bénéfices beaucoup moins tangibles sur lesquels on ne peut pas mettre un chiffre, mais où il y a un avantage à essayer de régler un problème transespèce, multi-espèces comme ça, tous ensemble. La rage, c'est assez évident quand même. La rage fait en sorte que les gens ont peur des chiens dans certaines communautés. Les gens se sauvent, alors que les chiens peuvent être vraiment une plus-value dans une communauté. Ils peuvent contrôler certaines choses, certains animaux, certains rongeurs, etc. Mais ça, on ne peut pas mettre une valeur là-dessus. Puis simplement, la relation homme-chien, c'est précieux, ça. Encore une fois, les Inuits, là, quand ils avaient les chiens traditionnels pour les traîneaux, c'était une relation vraiment spéciale. On a abattu leurs chiens. On a complètement détruit cette relation-là. Mais comment on mesure ça? Donc, il faut voir la plus-value de l'approche en santé en reconnaissant ce type de relation. Les éleveurs de vaches, les éleveurs de porcs, ils les aiment, leurs animaux. Ils les respectent. Ceux d'entre vous qui ont des animaux de compagnie, chiens, chats, on ne peut pas mettre de chiffres sur l'attachement qu'on a à nos animaux. Puis nos animaux sont attachés à nous aussi. Ça va dans les deux sens. Donc, c'est ça que j'espère que ça répond à la question.
I think maybe just to follow up on this, it seems like at one level, it's a very intuitive thing to ask somebody, what is your relationship like to the animal that provides your livelihood? But maybe perhaps when you're approaching institutional partners, they don't necessarily see it that way all the time. What has your experience been providing this One Health perspective to different types of partners who maybe don't think that way naturally?
Ça, c'est une bonne question, puis c'est pas facile. En fait, une des premières expériences qu'on avait eues, c'était justement la schistosomiase, mais c'était Schistosoma japonicum aux Philippines. Schistosoma japonicum infecte au moins une cinquantaine d'espèces animales. Donc, essayer d'éliminer Schistosoma japonicum en Asie sans penser multi-espèces et sans penser environnement, évidemment, parce que les escargots sont dans l'eau et les cercaires sont dans l'eau, est impossible. Donc, l'approche qu'on a prise, c'est qu'il faut trouver des partenaires qui, eux, sont convaincus, qui, eux, comprennent ces interrelations-là. Puis, dans notre expérience aux Philippines, on avait travaillé avec le RITM, Emilio Olveda, qui, lui, avait compris ça. Il avait compris que pour contrôler Schisto, il fallait comprendre quelle était la source de l'infection pour l'humain. Puis que si on regardait juste l'humain, on ne pourrait jamais l'éliminer. Donc, on a fait un projet de recherche dans ce cas-là où on a mesuré l'infection chez les bovins, les porcs, les chiens, les rats et les chats. Puis on s'est rendu compte que l'espèce qui infectait les chiens et l'espèce qui infectait les humains étaient assez semblables aux Philippines, ce qui est différent de la Chine où c'est les bovins. Mais donc, pour contrôler l'infection dans un cas comme ça, il faut impliquer les gens, il faut impliquer des vétérinaires, il faut impliquer non seulement des gens qui travaillent en santé, des travailleurs communautaires de la santé, mais aussi des travailleurs communautaires de la santé animale, pour qu'ils travaillent main dans la main, qu'ils aillent dans les villages ensemble, puis que quand ils vont dans un village, ben tiens, on va donner un peu de praziquantel aux chiens, puis on va vacciner les chiens contre la rage, pendant qu'on donne du praziquantel puis de la bendazole aux humains. Puis comme ça, et qu'on donne l'éducation à tout le monde sur les aspects sanitaires, les latrines, le lavage des mains, puis l'accès à de l'eau potable. C'est compliqué, mais c'est en ayant des partenaires comme ça qui travaillent ensemble, puis qui discutent, puis qui communiquent, puis qui se parlent, qu'on peut arriver à quelque chose.
Thank you. Pamela, I'd like to turn it to you as well. And maybe, I know that probably some folks listening today are wondering, what the NTD roadmap is that you introduced in your opening remarks. So perhaps you could talk a little bit about the NTD roadmap and the process that led to its development, and also perhaps respond to how did you approach this idea of partnerships in thinking about the roadmap? Because that was kind of one of the paradigm shifts that you spoke about in your opening remarks.
Thank you very much. So the NTD roadmap is a guiding document that presents a vision about that has been expressed and endorsed by the member states meaning the countries, the more than 190 countries that are part of the members of the World Health Organization, with a commitment to attain certain public health goals by the year 2030. In a nutshell, that's what it is. It's a journey. It's a document that outlines to us the vision and what we intend to attain by 2030. This roadmap is actually the second roadmap the World Health Organization is putting forward. There was a previous roadmap that was that covered the period of 2012 to 2020, which was mainly driven by partners. So remember, when I was speaking about partnerships, I mentioned the sort of the donors or the groups that have more money, for which there is a significant risk in them offering their own resources that they would normally be making profit from, versus an express need from countries. But the level of neglect around tropical neglected diseases is so great that sometimes the countries that are already battling with so many other things and are going to the same donors seeking for support for other program areas of work do not actually raise this issue themselves. So we find that while these billion plus individuals in the world are actually affected by NTDs, and in part related to what Margaret mentioned, and the comment she said when they said that, look, but these people are not dying, this doesn't kill. So there's a propensity to give priority to the diseases that cause mortality, high mortality, as opposed to the diseases which NTDs tend to be mostly, that cause morbidity. Individuals do not die, but they live in abject poverty and miserable and very unproductive, painful lives, So these individuals, in addition to trying to advocate for interventions for the other health needs they have, the needs of the neglected populations do not tend to be expressed. So for the previous roadmap, actually, it was through a lot of advocacy and science and a group of committed champions, including heads of CEOs of some of these farmers who came forward, having recognized this issue and said, we are willing to make these resources available, even though the need has not been that well articulated. Now, I'm going through this history to show you the difference between that roadmap and the current roadmap. The roadmap has the same goals. They haven't changed largely. We made a lot of progress towards attaining some of the goals by 2020. For example, for sleeping sickness, the number of cases were reduced far below the initially anticipated target. But for some other programs, the targets, we are still way, way off. In the meantime, over the last year, we increased our advocacy and countries understood that this is a program they need to own. So in the current roadmap, through an extensive consultation, there's been this demonstration and commitment, and countries of the world have signed off committing to alleviate the suffering of these billion individuals who essentially also constitute the bottom billion of the poor in health economic terms in the same countries. So this roadmap, while it is presented, it presents specific public health information, which you can find in very technical guidelines. But the main difference is advocating for a united common approach through partnerships towards achieving these public health goals. So I would encourage everyone to try and read the roadmap and familiarize themselves with this vision and approach. The public health goals do not change much, but how we work together to attain those goals, promote country ownership, which countries have signed off, is what is markedly different in the current roadmap.
Thank you. Thank you so much. And perhaps what we can do is also link the roadmap in the Whova app for the session so that folks can easily find it. We actually had a fascinating question come in online. And again, you're invited to submit questions over the course of this panel. The question asker says, this is the first time we've heard about the intersection of women's health with neglected tropical diseases and zoonoses. How do we ensure that truly intersectoral work within the same country can be operationalized, given the challenges of integration across not only different health areas, but also with multi-species surveillance? Maybe Margaret, I'll pass it over to you. And Hélène, you can also chime in on this one whenever you feel ready.
Thank you very much. You need to start from somewhere. And we've just started right now. And so far with the 1 year of the FAST package, I'll use that as an example. It hasn't been that easy because you need to be able to convince people about the need to ensure that we need to work together to deal with this person as an individual, but in a more holistic way. We talked about partnerships and Pamela mentioned a lot of things, but you see, the partnership has to be across all levels and across the entire spectrum. So WHO, yes, would have the guidelines and the roadmap and ask countries to take ownership, and countries must take ownership. But if the country is integrating and bringing partners together, but yet at the global level, partners come separately and in a vertical way to the country, then we have a problem. So partnership must be across the entire spectrum. We need to be able to say that, yes, we are working as an NTD program, but we recognize the importance of family health. We recognize the importance of HIV. We recognize the importance of water and sanitation because these women are using these water sources. But let's work together. Let's have a team together and discuss the issue in a holistic way for everybody to bring their ideas to the table to deal with this one problem. That's what I was saying.
Hélène?
Oui, c'est fascinant parce que les problèmes dont discute Margaret, ce sont des problèmes de silo, qui est le problème fondamental, la barrière fondamentale pour les partenariats transsectoraux. Donc, une seule santé, c'est le problème dont vient de parler Margaret sur stéroïdes. Parce qu'on parle carrément de secteur de l'agriculture, de l'environnement, de la faune, de la pollution, etc. Mais donc, je suis tout à fait d'accord avec Margaret, encore une fois, il faut parler avec les gens, leur permettre de réaliser que rien n'est en silo. Alors, autant les systèmes, entre le système génital, le système respiratoire, le système gastro-intestinal, ne sont pas des choses complètement différentes dans un être humain. Il faut aussi voir l'être humain qui a 3 porcs, 2 poulets, 4 chèvres dans son ménage, puis que tout ça fait l'ensemble du système du ménage et que le tout est dans un ensemble du village, de la région, etc. Ce qui demeure très, très, très difficile, c'est effectivement d'opérationnaliser la mise en place de programmes qui prennent en considération tous ces éléments-là qui, jusqu'à maintenant, ont été en silo. Puis, une avenue de solution, c'est de commencer très tôt dans les systèmes d'éducation à enseigner aux enfants que les choses sont reliées. Puis commencer à discuter dans nos institutions académiques, d'enseigner l'approche d'une seule santé, d'enseigner les multisystèmes, d'enseigner aux médecins que pas tout est divisé par organes, que les choses sont ensemble. Puis c'est comme ça qu'on va pouvoir commencer à changer les choses de façon durable, à mon avis.
Thank you. I feel sometimes like I'm having this like cognitive dissonance moment because this isn't the first panel where people have said, we need to break down silos in global health, right? This is not a new idea. And I find myself wondering, what are some of these roadblocks, right? You've mentioned one, Hélène, that maybe we need to be teaching kids at a younger age to think differently. Maybe, Pamela, if we are to think more at the institutional level, what do you think are some of the roadblocks that are preventing those truly intersectoral partnerships or that silo breaking mentality to take hold?
This is a very interesting question, which also speaks the need to be responsive to the times and also take advantage of the times. The previous or the current form of working in silos in particular way also had a genesis and a reason for its time. But that time is gone, especially if you look in the context of low and middle income countries, whereby at some period for decades, there was an exceptionalization of health systems that was skewed towards dealing with the epidemic of HIV, TB, and malaria. We have the tools and that's coming under control. That time is gone. So now with the MDGs behind us, we have the SDGs, the Sustainable Development Goals, that require for us to think and work differently. We also have a new generation of practitioners that is being trained and coming into global health space, coming into the economic spaces of various disciplines, and they're thinking differently, the new generation. One of the things we need to do at our various institutional levels, including in WHO, is really to package our messages in a way that can appeal and support the willingness of these new health practitioners and workers in forms to take this agenda forward in a holistic manner. I'll use the example of female genital stomatis, drawing on to from what Margaret said. For example, on an institutional level and a technical level, one of the things that our colleagues in reproductive health have done is prepare an algorithm whereby when you go to a health facility in a low-resource setting, a health worker can make a diagnosis based on asking particular questions. Despite our internal advocacy and technical advocacy, to have female genital stomatis incorporated and included, on a scientific level, it's recognized that it should be there because, as Hélène said, it's the same individuals, it's the same anatomy that a gynecologist is looking at and someone else. We are the same, in the same place. But these programs then receive funding that is particularly tagged to cause them to work in that manner and report in that manner. So while you find the health worker is willing and aware, but they are constrained by the manner in which the funding comes to enable them to do this work. So at an institutional level, we do need to find ways in which we remove these clauses or at least make them more accommodating to support this effort of working in a more holistic approach, and also put in place accountability frameworks such that if reproductive health is reporting on their various subjects of particular interest, they also mention FGS. And right now we have a good example that has come out through the collaboration of WHO and the UNAIDS, whereby in the strategic plan for UNAIDS, it has been specifically mentioned that as part of the strategy to achieve the goals and reduce the continued infections that are high in Africa, that there should be treatment of praziquantel for women in areas where schistosomiasis is endemic. So if someone goes for their HIV treatments, they are also screened for FGS and are also given praziquantel if they so need it. And the HIV community is demanding, as part of their own accountability internally, to have reports on treatment with praziquantel. This is a new thing. It's not difficult to do, but there is a certain open-mindedness that is needed and a new way of working to better use the resources and the opportunities we have now. This is just one example I presented in WHO, but we could have similar examples with FAO, with UNICEF, with UNFPA. It's ripe for working in this way now. That would be my submission. Thank you.
I guess this would also not be the first global health panel to complain about data and how it's collected, nor about funders and how they obligate data collection. But Margaret, I did see you nodding with amusement, and I'm wondering if you want to chime in.
Yes, I mean, I relate very well to what Pamela is saying. And I'm thinking of when I used to be in the Ministry of Health, working with different programs and different funding organizations coming in with support would say, this is my reporting template, use this. So somebody is supporting the NTD program, but Schisto comes with a different reporting template. It's collecting age, sex, the same thing that somebody is supporting Onco and says, this is my template. the reporting timelines are different. So you need to prepare one template for somebody in January, a different template for somebody in February. And your work is stuck because you have to fill in all these templates. Otherwise, you are not getting your next round of funding. The other thing is make sure my logo shows, make sure this shows. What happened to supporting the health system? So the person managing the health system is saying, I'm looking at all these conditions. I remember several years ago, there was this concept of putting money in a common pot so that the manager, having received funds, would know how to spread it out for different interventions that they are putting in place. Somehow it fell through the cracks. But let's go back to that, supporting the system, supporting the structures that are there so that the manager can decide that this is a problem for me and I need to focus a lot more attention on this rather than this, where somebody has a lot of money, it's not priority, but because the money has come, you need to focus attention on that. So it's something that needs to be paid attention to. We need to look at things together, support the systems, and then we'll be able to, we are talking about universal health coverage, talking about sustainable development goals. Let's support the health systems.
Thank you. We actually had a question come in that I think ties into this. You mentioned your time working for the Ministry of Health or the Ghana Health Service. What is the role of government? We actually haven't really touched on that yet, beyond maybe we'll get into country ownership, but what is the role of government in curating these partnerships or in facilitating them or in ensuring that they look one way and not another such that they're not siloed? How do you see that?
I always say that the SDGs, Sustainable Development Goals, are not legally binding, but our governments need to take responsibility. You know, if your chin is falling off and somebody says, hold it, I'm bringing something to help you tie, and you say, if you don't bring it, I will let it go, who suffers? So our governments, I think, have to put in a lot more attention and be able to have an agenda that everybody should buy into. If we don't have a plan and an agenda, anybody just comes with an agenda and moves along, and you have to bow to whatever the person says because they have the funding. Our governments must take responsibility, must fund research, must ensure that our programs are implemented in the way they are supposed to be implemented. We can reorganize our domestic funding. It may be tough, but if we see it as priority and we see it as something that would enhance the development, so health no longer becomes just a health issue, but a developmental issue, then we'll be able to look at things and put it in the national budget and ensure that it works.
Great. Hélène, one of the sort of dominant themes of yesterday's plenary was thinking about compassion, thinking about power and privilege in global health. And I'm wondering, how does that feature for you when you're thinking about partnerships in the domain of One Health?
Oui.
Just an easy question.
Ouais, c'est ça. Ben, pour commencer, je voulais juste rebondir sur ce que disait Margaret au sujet des gouvernements, juste pour commencer. Là, je vais sauter en dehors des maladies tropicales négligées pour parler de notre cher COVID-19. Pour mentionner qu'il y a quand même plusieurs pays en Afrique subsaharienne qui ont eu plus de succès à contrôler l'infection avec des mesures de santé publique, puisque des vaccins, de toute façon, on les garde tous pour nous dans les pays riches. Ça, c'était pas sérieux. Certains pays, par exemple le Rwanda, parce qu'ils ont eu plusieurs éclosions d'Ebola par le passé. La même chose, je crois que c'était en Guinée, ont mis en place des programmes où les ministères de la santé, de la faune, de l'environnement et de l'agriculture ont des rotations pour prendre en charge le programme Une seule santé. Donc, une année, il va y avoir le ministère de la Santé qui va prendre sous son aile les programmes transdisciplinaires. Puis l'année d'après, ça va être l'agriculture, puis l'année d'après, etc. Comme ça, on entend parler de tous les points de vue au niveau gouvernemental. Mais il faut être en mesure de faire la même chose au niveau communautaire. Et puis, on parlait de barrières, parce que je n'ai pas pu intervenir de ce côté-là. Une des solutions aussi pour les barrières, puis on vient de terminer une revue Scoping, dont le nom en français m'échappe d'ailleurs, mais qui démontrait que une des choses qui fonctionne le mieux pour mettre en place des programmes Une seule santé qui fonctionnent, ce sont des méthodes mixtes, à savoir des méthodes qualitatives où on intervient avec des anthropologues, avec des gens en sciences sociales, avec des économistes qui travaillent main dans la main avec des gens en santé, mais quand je dis santé, je parle de santé animale et santé humaine. Puis que ce sont ce type de partenariats qui permettent de fonctionner. La barrière, c'est que ça coûte très cher, puis c'est beaucoup plus difficile, puis si on veut faire du monitoring, donc un suivi de si ça marche ou pas, on parlait des difficultés des données, des données sur la schistosomiase. Bien, pensons schistosomia hématobium. Maintenant, on sait que schistosoma bovis a un phénomène d'hybridisation avec schistosomia hématobium. Donc, le problème de schistosome génital devient un problème une seule santé si on veut vraiment le contrôler. Donc, il va falloir des données chez le bovin aussi. Mais comment on fait pour que des bases de données bovins s'échangent avec des bases de données humaines? Puis, chez les animaux, il y a tout l'aspect de commerce aussi. Parce que quand il y a des maladies à déclaration obligatoire, les agriculteurs vont voir les animaux se faire abattre, sans communication, sans compensation financière. Quand il y a eu des cas d'influenza aviaire hautement pathogène, il y a des gens qui sont allés dans les villages et qui ont abattu les poulets. C'est ça, plus de poulet. Tu ne manges pas ce soir, c'est pas grave. Bien, les gens, ils font quoi? Donc, il y a ce manque-là de communication, puis le besoin de sciences sociales qui s'arriment avec les autres pour que ça fonctionne mieux. Je n'ai pas vraiment répondu à la question. Mais...
Do you want to respond to the question about power and privilege?
Power privilege, oh boy. Je vais donner la question à Pamela.
Okay, we'll return to you. Pamela, maybe taking Hélène's suggestion that we move to you with this question. I actually am curious how you think about power and privilege at World Health Organization, if at all.
Oh, well, power and privilege at the World Health Organization, big question. I will preface my comment by first and foremost recognizing and building on to what Hélène just said, that even as panelists, we are coming from three different backgrounds. There is a social science, there is animal health, and there is human medicine. But for us to be together here, someone had to help coordinate us and put us together to have this dialogue. So in response to the question about the role of governments, we should not undermine or undervalue the fact that coordination and dialogue needs to be supported and facilitated and budgeted for. It's not something that should happen as an act, a reactive to a particular political agenda or something. Because even in countries, when we do have our discussions and the Ministry of Health will say, I need to speak to the Ministry of Finance, I need to speak to the Ministry of Education, they'll say the only person who can coordinate us even in country is at the prime ministerial level. So really in the top echelons of government and leadership. And for countries that have actually done this, they are important countries from the Americas, especially in South America, whereby reporting on these types of intersectoral work is something that is done as part of the work of the prime ministerial office and functions. You actually see these programs and partners being forced to conform to this talk and guidance we are giving in guidelines. So I think what governments need to do is really put these issues at the top level of their leadership and have an accountability and coordination structure into which then these programs and various entities can be held to task. I also had a recent example from Tajikistan. It was very interesting how they do it. It is a planned thing. It's not just based on goodwill. So this is something governments need to do. And then when it comes to the question of power and privilege and at WHO, how we think about it. WHO, we are a secretariat for member states, number one. But we are not, so we support countries. We are not blind to some of these issues around power and privilege. Because if you look to what even just WHO, how WHO is, when it was constituted in the late 1940s, most of the current member states were still colonies. They were not in a position to be a member state of the United Nations. So a certain way in which power was established at that time continues to percolate through to even how we work today. More so when you look at certain blocks, whether it's Anglophone, Francophone, or whether it is Russian speaking versus Spanish speaking, you know, there's still power in those traditional structures that inform or that exist at the beginning of the organization. Nevertheless, with that said, increasingly we are seeing member states with more knowledge willing to express themselves and actually require that their one vote that they give on a particular issue carries the same weight and follow through with what other members are saying. So we do see the power, the effect of power and privilege playing out in the course of our work, but we also see it changing, given that member states themselves increasingly own this space, even though some of them came to the table late. And that's what we really want to see in terms of this discussion on shifts in paradigm and partnerships. Because some countries, I could name a few, are really strong on how partnerships work and who they report to in the country. And when it is at the prime ministerial level, the president's office, we see things happen differently, because ultimately they address the bottom line of every politician, which is poverty, emancipation, and economic development. That's what sells. So when we take it at this way, then we see the change in this whole thing of power and the dynamics at country level. So we need to speak not just biomedical language in terms of statistics, epidemiology. We need to speak across disciplines and to the economic bottom line, which is what the audience between medicine tends to hear better than what we ourselves speak about.
Thank you, Pamela. Margaret, do we also need to speak human rights in these partnerships?
We do. It's important. I mean, these days it's becoming an issue back in Ghana about rights. Whilst one group is thinking, yes, people have rights and even animals have rights, you have another group which says, what do you mean by rights?
Right.
Yeah. I don't want to go into the LGBTQ issues that are raging, but when it comes to somebody who has a health condition and needs to be treated, we should not take that person for granted, because the person has a right to good health. The person has a right to facilities. The person has a right to pipe-borne water in their house so that they don't have to go into the river to get infected by the snail. So there are things, and Pamela also touched on that, bringing people from different disciplines together. I look at it as health being, like I said earlier on, a developmental issue. When we were trying to bring LF as an important issue in Ghana, we did some economic analysis. And the thing that hits the people in government was the fact that if somebody has LF or a hydrocele, the person loses this number of days of work and productivity goes down. And that is what made them sit up. So the issues of productivity, economics, and the fact that as a human being in this country, I have a right to good health. I have a right to all the facilities that are important for me, are critical, and we cannot ignore them. We need to pay attention to them. But then we talked about issues of data and reporting on animals, reporting on human beings. FGS is new, and it took Ghana almost 4 years to be able to get it as an indicator in the health management information system. It is there right now. Now, the thing is, you need to get people trained to be able to identify and be able to report. And it is only when it is reported and presented at annual review meetings that people get to see it as something that exists and is important. Because we have this score sheet where we look at malaria, we look at TB, we look at HIV. And if we are beginning to look at FGS within the routine system, then people get to pay attention to it. A lot of our health workers don't know about it, but through FGS, we are trying to create more awareness. And we hope that come early next year, when we are looking at our data, we'll be able to see some reports. Right now, nobody's reporting anything, but we are hoping that once it is there, we'll be able to get some reports coming out, and hopefully something will be done about it.
Well, congratulations for getting that incorporated into the HMIS. No easy feat, surely. And then maybe to return to you, not on the question of power and privilege, but on something maybe related. What Pamela spoke to at one point was this concept of country ownership, which is very strong in the NTD Roadmap. What is country? How do you ensure that a community or a country owns the work that you're doing? How do you approach that partnership?
Oui, je pense que bon, moi, faut dire, je suis côté recherche, hein, je suis pas.
Yeah, that's I think it's really important.
Je peux peut-être vous parler un petit peu de l'exemple du projet qu'on a eu au Burkina Faso sur la cysticercose, qui va d'ailleurs parler un petit peu de pouvoir, privilège, mais aussi de s'assurer que les gens se sentent impliqués dans ce qu'ils font. Alors, ce qu'on avait fait au Burkina Faso, c'est qu'on essayait de développer un programme de contrôle durable pour la cysticercose. Évidemment, ce programme-là doit être multisectoriel. Alors, ce qu'on avait en tête en partant, c'est que facile, regarde, cysticercose, les porcs sont impliqués, c'est quand ils mangent des selles infectées humaines, on va les mettre dans des enclos, puis les gens vont les nourrir, il n'y aura pas de problème, les porcs vont grossir plus vite, les dames vont faire plus d'argent, tout va bien. On a fait des focus groups, on a fait des entrevues, on a impliqué des gens en sciences sociales, puis on a posé la question aux gens. C'est une bonne idée? Non, mais pas comme ça, mais qu'est-ce qu'on fait avec les porcs? Puis là, ils nous ont dit, non, mais c'est impossible. Pendant la saison sèche, on est incapable de nourrir nos propres enfants. Comment voulez-vous qu'on nourrisse des porcs? Alors, notre belle idée de chercheurs, une seule santé, on va régler le problème de la cysticercose humaine en s'organisant avec les porcs, ça n'a pas marché. Alors, il a fallu qu'on change complètement l'approche, puis ce que nous ont dit les gens, c'est qu'on sait que la défécation à l'air libre est un problème. On sait que ça rend les gens malades, puis c'est un problème qu'on voudrait régler. Alors, on servirait de bord, puis là, on tombe dans les problèmes de pouvoir et de privilèges, parce que le Burkina Faso avait adopté le CLTS, Community-Led Total Sanitation, comme approche principale pour régler les problèmes de défécation à l'air libre. Puis il faisait ça avec WaterAid. Alors, OK, on est allé cogner à la porte de WaterAid, puis on a dit, WaterAid, hey, on a des sous pour démontrer de façon scientifique l'efficacité du CLTS pour diminuer une maladie tropicale négligée qui provoque de l'épilepsie. C'est quand même beau, là. Hein? On leur donnait ça sur un plateau d'argent. Eh bien, ils nous ont demandé des montants financiers phénoménaux. Nous, on était dans 60 villages avec un petit projet du NIH, là, qui n'est pas trop mal, mais je veux dire, pour régler un village, tout notre budget serait parti. Donc, ça a été le problème. Donc, heureusement, on a réussi à trouver un autre organisme, une autre organisation à but non lucratif qui, eux, ont adopté une approche semblable qui est une approche participative. On est allé avec les gens, puis ils se sont rendus compte eux-mêmes, les gens, du problème, puis on a discuté avec eux des possibilités de solutions pour construire des latrines. Qu'est-ce qu'on fait avec les porcs, etc. Puis on a démontré que dans 2 des 3 provinces, notre approche avait fonctionné. Mais dans l'autre province, ça n'avait pas fonctionné. C'était 3 provinces collées les unes sur les autres. On s'est dit, une approche, c'est correct. Non, il aurait fallu qu'on aille encore plus dans les détails pour prendre en considération les variations d'une communauté à l'autre. Donc, il faut aller profondément dans les communautés pour que les communautés se sentent impliquées puis que ça devienne leur projet. Ce n'est pas mon projet. Nous, on amène un peu de directive, on amène, oui, de la directive, mais c'est seulement si les gens s'impliquent eux-mêmes et croient que c'est important que ça risque de fonctionner.
Thank you. We've had a very active number of questions come in online, but I'm hoping we have one in person as well. So please.
Hi, thanks so much. This has been a really excellent panel. I just wanted to kind of reflect a little bit. I know that, you know, NTD programs and One Health programs are so reliant on community health workers and community drug distributors. And I was wondering if you all could reflect on the partnerships with those who are kind of distributing the drugs and doing that on the ground work. Are those partnerships operating in a fair and equitable way? Or what do you see as kind of the future of those partnerships? Thank you.
Maybe Margaret, I'll turn this one to you.
Okay, thank you very much. When the NTD program started many years ago, we had the community drug distributors who were measuring people and then giving them their medication. A lot of other programs, malaria, EPI, latched onto this community approach and started using, most of the time, the same community distributors to implement their bed net distribution programs and stuff like that. So these days, I call them the professional community workers because they started looking for which program is compensating them the best. And then they would align themselves to that program. So when the health workers say, we have this program, they say, who is supporting this program? Because NTD expects that you do drug distribution over a period of time, but they have funding for just 3 days. EPI would pay you for the week that you are out there. They'll give you a t-shirt and give you blah and give you blah. Malaria would take you for this. So then they started checking which one works. So what countries are trying to do is to kind of institutionalize this community health worker thing. Some countries have included them as part of the health system so that you are there and supporting the system without deciding that today I want to work for malaria or tomorrow I want to work for another. It is not the same across all countries, but they are all working towards that. In the days of the Bamako initiative in the 80s, it was the approach. And then you had the community workers wanting to be part of the health system, but the funding could not support it. We are going back to those days, and I'm looking forward to seeing how countries are going to manage that process. But we cannot do without these community workers. They play a vital role. And in Ghana, with our community health and planning services system, which is the lowest level of service delivery, the community volunteers are part of the system, and they work with the health workers as they deliver their interventions in the community.
Thank you, Margaret. And actually, speaking of the Bamako protocol, Mali's actually also hosting a really interesting experiment now in community health workers that I would encourage folks to look up. Another question?
Thanks very much. Christina Zarowski, Université de Montréal. Thank you, Margaret, for those beautifully frank and straightforward comments, that echoes Judith Justice's work in Nepal 35 years ago about how when the program changed, they would just paint new signs on the trucks that were. I had two questions. I actually put them into the chat, but I didn't know if we were supposed to. One question for Pamela. When you started out talking about public-private partnerships and partnerships with pharmaceutical industries and all the wonderful charitable donations that they've made, speaking of power and privilege, we know that, in fact, in most countries of the world, the law requires that corporations maximize shareholder profit. And that's fine, but we need to have our eyes open about that and not romanticize it. So my question for you is, how do we actually build pro-poor and pro-equity public-private partnerships in this context? When should we rather be asking that companies pay taxes instead of making charitable donations? And a second question for Hélène, coming back to my first degree in biology and ecology, how can One Health help us think our way through something that's beyond the dichotomy of germs are bad? Let's eradicate things. No mosquitoes, we have no birds. No microbes, we have no humans. So how do we actually embrace all those pathogens that we're trying to eradicate? Thank you.
Thank you. Pamela, would you like to respond?
Thank you very much for that question. It's a very interesting question as well. It is true that at the moment, most of what we receive, the donations we receive are charitable donations that come from these pharmaceuticals, which operate on a for-profit basis. That being said, though, we also recognize and have tried to obtain other ways in which we can support this. And it's not very easy, because even if we use the taxation model, in places where there are not very clear and strong accountability mechanisms, the resources do not necessarily end up where we need them to be going. That's the problem. So for all the programs that we are working with, and also at WHO generally, we are looking to explore in which other ways we can strengthen and create other health financing models that will support the type of work that entities need to do. The health financing models we have now have taken us up to a particular point, but we know that one, it's not sustainable because some donations we have are time limited. Most of them, I think except only one, are time limited. And this is why, as part of country ownership, countries need to demonstrate that they are providing a financial resource base to support the continuation of delivering these interventions and ensuring that whatever barriers exist, financial barriers exist for the intended recipients, that they are removed. The NTD Roadmap actually has an indicator that is going to help us track how the individuals requiring interventions are protected from catastrophic expenditures, out-of-pocket expenditures, and the target is to reduce this by 90% by the year 2030. So in all this, how exactly we are going to finance, or that's going to be financed, it's not clear at the moment, but there are new avenues and structures that we're trying to explore to see how this could be done. Relying on charitable donations in the long term is not sustainable. We realize that. I hope that responds to the question. And if anyone has additional suggestions of financing models that could support the NTD work, given that it's very multi-sectoral, that's also welcome. The other thing I need to mention is we are finding that there's actually resources that, for example, the water and sanitation sector, through whether it's development work by UNDP or water aid or whatever, they have already mobilized a certain amount of resources, but the entire potential of those resources has not been exploited due to the underutilization of synergies that exist. So even before we go out asking for more money, we need to use what we have better, and then put in place financing models that can support the sustainable implementation of these interventions over time.
Yes.
Thank you.
Thank you, Pamela. And then just before we go to you, I'm going to reframe the question, because we actually received a fair number of questions kind of about One Health in general. And maybe could you just tell folks, where would you suggest they look to learn about One Health after this panel's over?
OK. Oui, oui, c'est une bonne question. Il y a plusieurs ressources, en fait. Les plus importantes, je dirais, il y a le One Health Commission, qui a un site web. Il y a le One Health Initiative, qui a aussi un site web. Ces deux organismes-là ont vraiment beaucoup de documents et de références sur le sujet. Il y a aussi un livre de Jakob Zinstag en Suisse, qui est uniquement sur l'approche une seule santé. C'est un bon bouquin, mais le chapitre d'introduction est vraiment intéressant. Puis évidemment, il y a de plus en plus avec la COVID, là, qui est d'origine animale, il y a de plus en plus de littérature qui sort, puis tout le monde est un expert en une seule santé maintenant, mais c'est correct. Les gens en parlent, puis on commence à essayer de mieux comprendre comment ça marche.
Perfect. So we have about 5 minutes left to conclude, and I'd like to have each of you say something. And I'd like for us to imagine a hypothetical scenario. So this panel is coming to an end. Pamela, you're in Mombasa, we're in Ottawa. You put your mask on, you head out to the street, and you come across the global health genie who is able to grant a single wish. And this global health genie is only going to grant wishes on the topic of partnerships. What do you wish for?
Starting from me.
Let's start with you.
Easy, eh?
And we have 5 minutes
We
left.
have 5 minutes. Okay, so I'll tell the genie to ensure that we have respect in our partnerships. Each of us has a different capacity. Each of us comes from a different discipline, and everybody's discipline is important. We must learn to respect each other to be able to deal with a problem.
Great, thank you. Pamela, you're in Mombasa. The genie magically transports there. What do you ask for?
Thank you. I might actually see one here.
Good point.
Yes. So I would ask for something that is aligned to the topic of this panel today, which is basically to do with water, women health.
Mm-hmm.
And I would ask for more representation of women in leadership positions in whatever partnerships that I establish, whether it be at a global level, national level, or more importantly, even at community level. So while we even speak of country partnership, what's more tangible and impactful is having community ownership, whereby women are leaders in this position. They are the women at the front line of suffering from the fallout from NTDs. That's what I'd ask for, along with, of course, in so doing, if you put women there, the agenda also of supporting human rights for women, sexual reproductive health rights for women would be farther along than it presently is. Thank you.
Thank you, Pamela. Hélène?
Oui, c'est difficile d'ajouter à ce que mes co-panélistes viennent de dire. Mais bon, dans mon cas, je pense que j'aimerais ça avoir une belle bombe qui brise les silos. Ce qui fait que tous les éléments du silo pourraient se mélanger et que les gens puissent justement commencer à communiquer et à se comprendre pour rebâtir les choses de façon horizontale. C'est tout ce que j'ai à dire.
Wonderful. And an explosive end to this panel. Thank you all for joining us. We encourage you to continue the conversation in the Whova app. Merci beaucoup. And please join me in thanking our panelists today as well.